All right, we're going to be getting started now.
All right, well, thanks everyone and good afternoon. I'm here and really happy to share over the next 30 minutes the indications for lung transplant and when patients should be referred to a transplant center. So the outline for today will be to just briefly review a little bit about the history of lung transplant, including the history here at Henry Ford, some general guidelines to candidate selection, how an individual's comorbidities will weigh into their eligibility, and then finally to conclude with like the 5 most common diseases that we offer transplant for and when those diseases should be referred. So I think just to begin, the history is interesting with lung transplant. In the 60s, heart transplants were performed very successfully. And I think that spurred on the first attempt at a lung transplant in 1963 at the University of Mississippi. This individual had almost every contraindication you could imagine. He had lung cancer, he had renal failure, he was a smoker. And so they attempted this and he lived for 18 days. Then there was a big hiatus before transplant was really started more nationally. And in 1983, the first successful single lung transplant was performed by Dr. Joel Cooper at the University of Toronto. This was in an individual with IPF, and he lived for 6 years with great quality of life. In 1985, our registry for heart and lung transplant was created, and I really want to emphasize to everyone how much this has assisted us in the field of lung transplant. It's really allowed us to be where we are today. Everyone that gets a transplant in this country and internationally has to register with this registry, and it gives us a lot of information on postoperative survival, on immunosuppression, as you'll see, I think, when Lisa speaks. And just in general, it has been just a great resource for us. In 1986, same surgeon, same place, the University of Toronto did a successful bilateral lung transplant in an individual with cystic fibrosis who survived for 15 years. So a great success story. And in 1990, the first successful living-related lung transplant was performed. This has not really caught on. I've just heard this adage, it's the only procedure that we do that can have a 300% mortality. So it's very risky for both the donors and the recipient, and has overall not really caught on to any wide-scale use. So 35 years after the beginning, we now have over 63,000 lung transplant recipients reported to our registry, and really a wealth of data. These slides are available to everyone on the web. They're published in April, and they focus on different points of lung transplant. And then just finally, I think the most important advent that really allowed us to transplant successfully is the understanding of calcinuric drug inhibitors and cell cycle inhibitors that were really pioneered in the 70s and has allowed for our success. So what about Henry Ford? We began our program here in 1994. I was a fellow, and you see in the upper picture, Dr. Higgins, who was in the middle, was our cardiothoracic surgeon who brought the transplant to Henry Ford. Michael Basha, you'll probably get referrals from him. He's practicing in Port Huron, was the medical director at that time. And in the lower picture on the right, you'll see our first recipient. Her name is Jackie Brooks. She had alpha-1 antitrypsin deficiency, and she underwent a successful lung transplant and lived for about 2.5 years. I want to highlight some registry slides for everyone, just because I think that it gives a good flavor of what is happening recently with transplant. So this is transplants by year. You can see the exponential growth that has happened, and it's continued until last year with COVID, where we have reached a record of 5,000 transplants performed per year. And you can see in the purple highlighted here, the majority of transplants being done in this country and internationally are now bilateral lung transplants, as opposed to in the early days of transplant where mainly single lung transplant was offered. I like to share this slide because I think it's not really well understood in terms of center volume. So Henry Ford will do probably before COVID between 30 to 40 transplants a year. So that places us in this category of intermediate volume center to the high end of intermediate. But I think what I want to really express and show you is that there's really few centers internationally and in this country that are performing more than 50 transplants a year. So those centers are unique and are not really everywhere. Most centers, as you can see, are falling into this range of between 10 to 20 transplants per year. And it's also surprising to me how many centers exist that are doing 1 to 4 lung transplants in a year. This highlights a little bit about what diseases are being transplanted, and I'll bring your attention to really the white bar, which shows that after LAS was created, and I think Dr. Pinto is going to talk a little bit more about the lung allocation scoring and how it's affected who's transplanted. But I'll highlight here that the majority of lung transplants have shifted from individuals with COPD to individuals with interstitial lung disease, particularly those with UIP. So just some general guidelines to patient selection. We always want to be able to maximize medical therapy. If there are other options to keep people alive with their lung disease, even with oxygen, we will offer those first. We look for individuals who have a limited life expectancy, ideally greater than 50% likely that they're not going to survive at 2 years. And we want to make sure also that when we're transplanting people that they have a survival benefit. So we want to make sure that they are going to survive more than 90 days and ideally many years with their lung transplant. Individuals must be ambulatory with a potential for rehabilitation after transplant. We look very carefully at their psychosocial profiles. People with unstable psychiatric disease, suicide attempts, schizophrenia in general are not candidates for transplant. And then everyone needs to have an adequate support system. And with that, I mean at least 2 people, an adequate car that can drive them back and forth. Unfortunately, we're not able to transplant people who are using transportation services to come back and forth to clinic just because of the unreliable nature of those services. And then we also look at the non-pulmonary aspects of an individual that might limit their life expectancy. One of the most changing categories of lung transplant is age eligibility. And when we began transplanting here, we used to say anybody over the age of 60 was just too old. And now that has been pushed up and up and up. And we think now probably over age 75 is very unlikely to be a candidate. But age is really also about comorbidities. So what we're willing to accept in a 50-year-old, we may not be willing to accept in a 65 or 70-year-old. And a slide I'm going to show you will indicate how many transplants are being done now in the category over 65. Interestingly, when we look at survival, we see that although younger individuals less than 60 have better survival, the category of 60 to 70 versus over 70 actually has no difference in survival. So I think that has encouraged us to think about the right candidate over age 70 being eligible for this procedure. This is the registry slide that highlights age, and I'll bring your attention to the very top red portion, those over the age of 65, and we can see that that has been the fastest growing age group of people getting transplanted. And that probably also goes along with the disease that's been the most commonly transplanted, UIP, which is a disease of the elderly. Some of the absolute contraindications include active pulmonary infection. You know, we've had a number of these recently where patients have, acute cholecystitis, or they have positive blood cultures, or they have osteomyelitis. All of those things would contraindicate transplant until they've been completely eradicated. We do not transplant active Mycobacterium tuberculosis or anybody with a history of malignancy that's not been considered sort of cured. However, there are a lot of fluctuating diseases. We used to say prostate cancer couldn't get a transplant, and now there's a lot of evolving literature that, depending on sort of the treatment, your Gleason stage, the prognosis of that cancer, that may be accepted without 5 years of disease-free survival. One of the most important things we pay attention to is body mass index. We use, the value of 35. Some centers will use 33 or less. And there is good literature that supports the increase in morbidity and mortality after transplanting obese individuals. We look carefully for tobacco use. You have to be substance-free, including all forms of nicotine, for at least 6 months to qualify for transplant. And then we also want to make sure that people's other organs are functioning properly, particularly things like their liver with cystic fibrosis or alpha-1 antitrypsin deficiency. With scleroderma, we want to make sure that we understand fully the disease and how it's affected their GI system. And then coronary disease, if it can't be stented or bypassed, would be a contraindication, or someone would need to qualify for heart-lung transplant. And then finally, obviously, if you have impaired renal function or liver function, or some problem with your brain, particularly active seizures, would be a contraindication unless they've been controlled. Let's see, this is okay. So we also look at comorbidities, and oftentimes if you think about the patients that we're seeing for lung transplant, the disease themselves have created these comorbidities. So, we want to make sure that if somebody's on a ventilator, we do transplant those individuals, but they need to be ambulatory, ideally awake, alert, and participating with mobility and getting out of bed. We look at their nutritional status, which I'll talk about in a moment. If they've had previous thoracic surgery, particularly talc pleurodesis is a very high risk for transplant, and we would love to be able to only use the lung that maybe didn't get talc pleurodesis if that's possible. Steroid use, we want to make sure their steroids are minimal, ideally 10 milligrams a day if it's a chronic steroid user. And we talked about malignancy and coronary disease. Acid reflux is something that does pose risk for chronic rejection, and we want to understand that going into transplant. And in addition, osteoporosis. So a little bit about nutritional status. We really want to have our nutritionists seeing everyone who is either overweight or underweight. And if somebody has a BMI of over 35, we're going to mandate they lose weight to get to 35 in order to be listed. But it's not just as simple as that. We want them to continue losing weight, which is oftentimes a real struggle for our patients. We have successfully used the weight loss program that's a part of Henry Ford Health System with several patients recently. We also look at malnourished individuals, and these will tend to be patients with cystic fibrosis, for example, some individuals with COPD where their BMI is less than 17. And in those individuals, we have had success by offering GJ tube placement as you're trying to enhance nutrition in order to be listed. All patients that we see must be participating in pulmonary rehab and ideally exercising daily. So this is a sort of a nice review of obesity and underweight. And I think my takeaway from this review is really that obesity, which you'll see particularly in those with COPD and IPF, really has a very, very strong impact on long-term, short-term and long-term survival after lung transplant. We do look at underweight, and we can look at that in this area with individuals with the disease of cystic fibrosis. And we can see that it does play somewhat of a role, but it doesn't seem in the first year to be quite as significant. So in general, I think this is the sort of data that has made us really pause and make sure that we're looking at weight carefully. and not offering lung transplant to individuals with BMIs over 35. So some disease-specific indications. So these are sort of the 5 most common diseases that we're offering transplant to. And as I said, emphysema used to be the predominant disease and now is really second to ILD. The problem with emphysema, and you'll see this as you follow patients long-term, is it's very hard to predict survival with emphysema. You will see people who have been in respiratory failure on a ventilator and see them back 3 years in the clinic. Their quality of life is still terrible, yet they're still alive. And so there have been a number of measures that have tried to predict survival, which is what we're trying to tease out when we offer transplant. And one of these is the Bode index. So we'll always calculate the Bode index when we see individuals and in evaluation. And we know that when the Bode index is greater than 7, that's suggested that they have an 80% mortality at 4 years. So these are really the people that we are considering for transplant. And this is just the Bode index scale. And again, it's a very good predictor for what we have. So referral to transplant, we like to see patients maybe when their Bode is less than 7, between 5 and 6. Their FEV1 should be significantly impaired, less than 25% of predicted. And most patients that we put on the transplant list will have resting hypoxemia. So not just the patient that exerts themselves, but their blood gas will reveal a PaO2 of less than 60. And hypercapnia is also a poor prognostic sign. So if their PCO2 is over 50, that in turn should prompt a referral. Pulmonary hypertension or evidence of right heart failure also has poor prognostic findings with COPD. So UIP, the most common disease that we offer transplant to, and unlike COPD, we know that if somebody has pure UIP, their survival is very poor. So the median survival from the time of diagnosis to death is 3 to 4 years. The pace of decline is individually variable and oftentimes stepwise, where people will have periods of stability for months or even a few years, and then have an acute exacerbation. And these acute exacerbations have very high mortality associated with them. It's common that we will see patients in clinic that will say, you know, I had UIP, I had 2 episodes of pneumonia in the last year, and now I'm much worse. And probably those episodes of what they were told were pneumonia could likely be exacerbations of UIP, and they just do not return to their baseline. So we want to see all individuals with a diagnosis of IPF at the diagnosis time, so we can start preparing even if they're not on oxygen. We know some of the prognostic findings that offer worse survival are UIP on biopsy as opposed to NSIP, which likely will have more of a steroid responsiveness. If they have more honeycombing versus ground glass on their CT, a low diffusion that's changing over time is a poor prognostic factor. And then generally, once people are needing oxygen, even on exertion with IPF, we look at them as candidates to be listed at that point. Pulmonary hypertension portends a very poor prognosis together with UIP, with very limited survival. And finally, if you end up in the ICU on a ventilator with UIP, you are extremely unlikely to leave without a transplant. So hopefully we see people before that point. Cystic fibrosis and lung transplantation is long-term survival is really, for most individuals, will require lung transplantation, although the care with CF has improved so much these days that a lot of people are surviving longer without transplant. The Cystic Fibrosis Registry really has contradictory results regarding when people should be transplanted. But in general, it's important to remember that young females have a much worse outcome than do older males. And we want to be able to pay attention to resistance patterns and hope that as these individuals with Pseudomonas are getting more and more resistant, they're being referred to a transplant center, even if they have preserved lung function. So we look for people that have an FEV1 of less than 30% predicted or a rapid decline in their FEV1, or if they're female and young, and they have any of the following criteria: an oxygen requirement, hypercapnia, pulmonary hypertension, low 6-minute walk distance, or even life-threatening hemoptysis with preserved lung function is an indication for transplant. So pulmonary hypertension, probably, I think, in the field of pulmonary medicine, the thing that we've seen the most medical advance in terms of improving not only survival, but quality of life. In 1991, the median survival for IPAH was less than 3 years. And remember, this is typically a disease of young women. And the prognosis now is really after people have been maximized on medical therapy and how functional they are. So what is their New York Heart Class after, multiple medical therapies have been introduced? And I think that the 3-year survival in individuals who remain class 3 or 4 after medical therapy is maximized is only 33%. The good news is that the majority of people will have response with medical therapy. The timing of referral is if you remain New York Heart Class 3 or 4 despite maximal medical therapy, you have declining 6-minute walk distance, and oftentimes those two go hand in hand. Anybody who has a diagnosis of pulmonary veno-occlusive disease, very, very rare, but also not generally responsive to medical therapy, should be referred to lung transplant. And then finally, if somebody has cath data that's showing that they have very low cardiac index or high right atrial pressure despite medical therapy, they should be referred to a transplant center. We see a lot of sarcoid in Detroit, and we have transplanted a lot of sarcoid relative for our program size versus other similarly sized programs. It's important to remember the minority of patients with sarcoid will ever progress to a point where they need transplant. And the variable nature of this disease and very protracted course also makes it hard to predict survival. We do know that poor PFTs do not predict survival with sarcoid. And so just because somebody has really awful PFTs does not necessarily mean that they will have a survival advantage with transplant. Transplantation is definitely complicated in this group of patients by the systemic nature of sarcoid and the multi-organ system involvement with sarcoid. And I think for your boards, a good thing to remember is that sarcoid is one of these diseases that we transplant that recurs in the transplanted lung. One of the few diseases that we'll see granulomas in transplanted lungs. They oftentimes don't have clinical consequence because of the immunosuppression, but it does recur. So when do we transplant individuals? I think their functional class is very important. They must be on oxygen, but typically pulmonary hypertension together with a history of fibrotic sarcoid in the lung is what really tips us to think that their survival would be better with transplant than it would be if left to medical therapy. This should say retransplantation. It's generally not used for primary graft failure, although for sometimes that has been done. It's predominantly used for chronic lung rejection. However, patients need to meet the same criteria they did the first go around. And oftentimes after long-term immunosuppression, their renal status is not very good and other comorbidities are much greater than they were on their first transplant. So finding the right candidate for retransplantation is important. I think probably Dr. Pinto will highlight that the LAS system does offer an advantage to retransplantation. And we're seeing many more cases of retransplantation happening these days than we did 10 years ago. So I want to conclude by just telling you that lung transplant in the right patient is amazing. It offers a great quality of life if we're carefully selecting our candidates. We need to pay careful attention to their comorbidities. And that, I think, will help us to maximize post-transplant survival. And then I think also the natural history of somebody's lung disease is going to indicate when somebody should be on a transplant list. Because again, we are looking in our selection meeting for who is not going to survive with the lungs they have and who would benefit with a survival advantage to transplant. Who knows, if we had all the lungs in the world, maybe we would be able to offer this as we did in the beginning to improve quality of life. But right now, what we're really looking for is how to improve survival. So thank you. I think Lisa's going to talk next, and then at the end, we'll try to answer any questions that you all may have. So, thank you.
Water, Thanks. Okay. Do I need to do something separate to go to the next one, or? Oh, okay.
Start sharing from the first slide. Slideshow.
All right. So I am today going to be talking about rejection. So I'm going to be talking about acute and chronic rejection. And we'll talk about different types of allograft failure as not only a spectrum, but also different entities. So today, I'd like to describe for you the different types of graft dysfunction. We'll talk about acute rejection, and we'll talk a little bit about whether it's cellular versus antibody mediated. We'll talk about a word that Dr. Allensbach mentioned, CLAD, which stands for chronic lung allograft dysfunction, and what that means. It's a relatively newer term. 10 years ago, we really weren't talking in terms of CLAD. And we'll talk about chronic rejection in terms of BOS, or bronchiolitis obliterans syndrome, versus RAS, which is restrictive allograft syndrome. So hyperacute rejection is the process where the patient's allograft becomes non-functional within just hours or days. This tends to be antibody mediated. We see this very rarely because it's largely due to ABO blood group incompatibility, and we have so many checks and balances to prevent errors of that nature. It is more likely to occur in highly sensitized individuals. Just for your knowledge, we do not do HLA matching of donor to recipient, similar to what bone marrow transplant patients do. What we do is we match blood types, and we will look at individuals, the recipients, to see whether they harbor pre-existing HLA antibodies. And we'll talk a little bit more about that, but we do not do matching. The treatment, if a recipient is unfortunate enough to have hyperacute rejection, would be pheresis and IVIG. So primary graft dysfunction, we assess the patients at days 1 and 3, and you can go day by day and assess their grade of primary graft dysfunction. Grade 0 is basically normal X-ray and normal PaO2 to FiO2 ratio. And it can also be progressive, where you have ARDS type picture where you see diffuse infiltrates and your PaO2 to FiO2 ratio can actually be progressed to be less than 200. Before I move on to the next slide, those who are at higher risk for PGD might be those who are obese. That's shown to be a risk factor. Also those who have pulmonary hypertension, and those who also have a lot of pre-existing HLA antibodies. And usually it's basically supportive care. There's no specific treatment. You know, we try to keep our patients as dry as possible, as most of you who have rounded with us realize. But a lot of it is kind of playing a waiting game. So lung allograft dysfunction, if say a patient post-transplant comes in and their spirometry is declining, you want to try to differentiate whether is this something acute or is this something chronic. And if it's chronic, then we would wind up looking down the CLAD protocols or versus acute. So if we're talking about acute rejection, you need to, or acute decline, you want to think about things like infection, acute cellular rejection, or other different causes. If we're suspecting that this is more chronic, as defined by a drop in your lung function so that it's less than 90% of baseline, so a drop in 10% for a few weeks, then you try to think of, okay, well, what could be causing it? You may not be able to find a specific cause. Specific causes could also be, you know, does this patient have persistent acute cellular rejection? There is also an entity where you have azithromycin responsive, allograft dysfunction. And in some of those patients, some of them may actually respond to azithromycin, and you can actually do BALs, and BA neutrophilia would predict that there may be a better response. Other things that can happen to cause a decline might be anastomotic strictures, disease recurrence, which is not very common other than you see it sometimes in sarcoid. But I can't even recall any patient that I've seen who's suffered chronic decline due to their underlying disease recurrence and their allograft. Other things, think about the diaphragm, think about somebody who maybe had a single lung transplant, and perhaps the contralateral side is hyperinflated. So let's talk a little bit more about cellular rejection. So what are the factors involved? I always tell patients and their families that, remember, the lungs are always going to be exposed to the outdoor environment. These lungs tend to be more susceptible to inflammatory injuries or infections, environmental exposures, and also just the innate immune activation system in your body. It is T cell mediated. What you see are lymphocytic, perivascular, or bronchiolar infiltrates. So it's graded with an A and a B. The B is the bronchiolar component. The A component is the perivascular component. And we're generally treating for the A component. Can go from 0, which would be no rejection, to A4. I've never seen an A4. Dr. Allensbach may have, but I haven't. I have seen a few A3s, and in general, those are patients who have been very non-compliant with their medical regimen. In over a third of these patients, they may be asymptomatic, which is why we tend to we have a biopsy protocol where we look at them at 1, 3, 6, 9, 12, 18, and 24 months. Some centers don't have routine surveillance. We have kind of tried to stick with that because we do find things. And they actually have done, they have looked at this. And I think that those who actually have a protocol versus those institutions who don't have a protocol, we wind up doing fairly similar numbers of biopsies. And the reason is, if they're not doing routine, I think that they're biopsying more easily or sooner with maybe less symptoms. So winds up kind of being the same. This is just to highlight how the percentage of patients who in the first year wind up having some element of cellular or acute rejection. And as you can see, even looking at the varying ages, I would say somewhere between 25 and 30% of patients at 1 year have probably been treated or found to have at least some element of acute rejection, which is typically quite simple to treat. So this is just a picture of acute rejection where you see the perivascular infiltrate. So if you look at all of this cellular material around the vessel, so this would be, I don't think this would be an A1. I'm guessing this would probably be an A2. When you round with us, when we go see patients, you know, if you're seeing patients in the clinic or we're rounding in the inpatient service, we will often bring you to the pathology with us and we'll review some of these slides so that you can at least get a picture and get a sense of what we're looking at. So when do we suspect acute rejection? We suspect it with a decline in lung function, with symptoms, or a change in chest x-ray. The diagnosis is histopathology, and you need to exclude significant infection. Now, can you have concomitant acute rejection with infection? Yes. And I think we take patients on a case-by-case basis and try to determine what is the driving process for that particular individual. There are no good surrogate markers to replace histopath, and patients who have recurrent episodes of acute rejection are at risk for chronic rejection. When I first started doing transplant with the team, we were not treating A1, which is minimal rejection. We were treating A2 and above, but because literature has come out showing that recurrent episodes of acute rejection are a risk factor for chronic, we now do treat it. So this is just one of our patients who I thought would be a good patient to kind of illustrate how, you know, simple, unusual findings might lead to or might be related to rejection. So this is a woman, I believe she was transplanted for emphysema, and she comes for her 3-month surveillance bronchoscopy. She has had an increase in cough for 3 days, a recent decline of 17% in her spirometry. And if you look at her chest x-ray, and what I'd like to point out is that she has just a very small right pleural effusion. So she's biopsied. She has A1, which is minimal acute rejection, B0 on histopath. All her cultures are negative. So she's given a steroid burst and taper. These patients, they'll take 40 milligrams twice a day for 5 days, then 40 a day for 5 days, then we drop them down to 20. And there's no, you know, you can't look in a textbook. Everybody does things a little bit different. That's the way we've been doing it here. And I think it works. It seems to work pretty well. So you can see on her chest x-ray that her right pleural effusion after treatment is completely gone. So this is another example of a patient. This is a 60-year-old male who's 34 months post-bilateral lung transplant for emphysema. He comes to see us up in clinic. I remember seeing him up in the hallway on K17. That was before I think we even had clinic downstairs. He comes in with 2-week history, progressive cough, dyspnea, some low-grade fevers, a huge drop in his FEV1. He's tachypnic, has bilateral expiratory wheezes. Of course, he gets admitted. I put him in the ICU. And he undergoes transbronchial biopsy, which shows capillaritis. On micro PCR, he has RSV. He also, every time we biopsy a patient, we also send blood for donor-specific antibody, or DSA. And this patient, if you look at his images, you can see he's got evidence for capillaritis. The other thing, when we have a patient who shows obvious evidence for capillaritis and has had a decline, is we will also have the specimen stained for C4D. C4D is a stain that we use to help us diagnose or to help us diagnose acute cellular rejection. I'm sorry, acute antibody-mediated rejection, or humoral rejection would be another term. And if you take a look at this, red kind of staining right here, that is your C4D. C4D, unfortunately, is fairly nonspecific. Sometimes infections, if you biopsy a patient who has an infection, sometimes you can get C4D staining. So there's not just one factor that tells us this patient has antibody-mediated rejection. We'll talk about it a little bit more, but this was a good example. So this patient has really clear evidence for antibody-mediated rejection. So the concept is of immune activation. So the B cells or the plasma cells produce antibodies, or donor-specific antibodies, that are directed against the donor lung antigen. It's important to recognize that AMR, or antibody-mediated rejection, and acute cellular rejection can coexist. The DSA may not be detected for a variety of reasons. There's a phasic release, so you may miss it. The DSA maybe is not yet detectable. The DSA may be absorbed into the lung allograft, so you can't use that factor to completely exclude either, which sometimes makes the diagnosis of AMR a little bit challenging. Another thing that we can also check is a C1q assay, which is a measurement of basically complement activation, and that can also help give us information. So, the other term that you use is humoral rejection. Other thing that it's important to know is also that these patients can be sensitized coming into transplant. So you can have antibody-mediated rejection after transplant, but if you take a look at HLA antibodies, these can be detected pre, or they can be de novo or new post-transplant. I think I had this on another slide, but those patients who have high numbers of HLA antibodies detected pre-transplant, those patients are at higher risk for early BOS, or early chronic rejection. You can also have donor-specific antibodies, but also non-donor specific to other types of entities. So you can have endothelial cell antibodies or MICA antibodies positive. And I know other centers have seen that. We've sent off for some of these. I myself haven't seen one of these yet. These patients, they can be complicated, are complement and non-complement mediated. So a DSA, new DSAs after transplant can be seen in 25 to 55% of patients. They are associated with decreased survival. As I mentioned, they're associated with an increased incidence of early BOS. The persistence of a DSA or autoantibodies also can correlate with poor outcomes. If you've ever rounded with us or looked at some of these antibodies, there's class 1, class 2 antibodies. Class 1 antibodies are fairly easy to clear from the system. Class 2 antibodies are very difficult to clear. And most of this we talked about, but I think the one thing that's important to understand is in those patients who we do have preformed HLA antibodies, centers have kind of gone back and forth. They've tried to clear these HLA antibodies by using plasmapheresis pre-transplant and other agents. But there is no consensus on the treatment of these preformed antibodies. And I think, we've never done that. And I don't think that it's been shown to be all that helpful. So again, just to kind of highlight, for humoral rejection, just like acute cellular rejection, you may see a clinical decline. You'll see donor-specific antibody. You can see capillaritis and C4D on histopath. In order to treat for humoral rejection, we give IVIG, but it also is given at the same time as plasmapheresis. So we give the pheresis, which removes the antibodies. The IVIG blocks the binding of any remaining antibodies. And then at the end of our treatment protocol, we give rituximab, which is an anti-CD20 monoclonal antibody, and that helps to deplete the B cells. And then patients are generally treated for 6 months with continued ongoing IVIG after we treat the patient in-house. And this is just, I don't know that it's important that we go through all of this. So several years ago, we actually had, as part of the ISHLT working group, we had a meeting where we talked about how are we going to diagnose antibody-mediated rejection? What factors give you a definite, probable, possible? And I would say there's probably 150 people in the room and absolutely no exact consensus on how to do this. So I think the best that you can come up with is we look at 4 things generally. We look at allograft dysfunction, histopath, C4D, DSA. If we don't have an alternative reason and the patient has histopath that is not quite normal, but is positive for C4D, and they also have a DSA, then we will call that AMR. If the patient only has a DSA but doesn't have any of those other factors, then probably it's unlikely that they have humoral rejection. And all the other combinations are somewhere in between. So we have to take a look at each of our patients individually to figure this out. So moving on, this is another sample of one of our patients. He's a 58-year-old male post-bilateral lung transplant for emphysema. He comes in with a progressive increase in dyspnea. We have ruled out rejection and we've ruled out infection. And as you can see on his CT scan, he has mosaic attenuation. So this darker area adjacent to this kind of whiter area. And when you see that, and he's also had a decline in FEV1, and you can see how profound this is. You know, he had 3.7 liter FEV1, and then a year later, he has 0.5 liters. And obviously that was a very, very rapid decline. And this is a patient who has developed rapidly progressive BOS. So here's another better example. You know, when we are looking at CT scans to try to determine whether or not somebody has BOS, we specifically say that's what we're looking for, because they will do inspiratory and expiratory views. And if you look at inspiratory views compared to expiratory views, you can see it kind of highlights the air trapping. So obliterative bronchiolitis, this is a path specimen that shows all of this hyaline membrane, which is occluding the distal bronchioles, and there. And basically it obstructs their airways. So let's talk a little bit about chronic lung allograft dysfunction. And BOS is one of the categories of CLAD. So if your pulmonary function after decline is not restored to greater than 90% baseline and persisting for 3 weeks, we can call it CLAD. It embraces all forms of chronic lung dysfunction. It does not imply an inability to improve with treatment. The things that we'll look at for investigations, we'll do complete we can do pulmonary function studies, biopsies to exclude acute cellular rejection. We'll do BAL with cell counts and high-res CT that we just took a look at. The subtypes of CLAD and include things like BOS. ARAD stands for azithromycin responsive acute dysfunction. AFOP stands for acute fibrinous and organizing pneumonia, which I think over the years, we're recognizing it more pathologically or we're seeing it more, I'm not sure. RAS is restrictive allograft syndrome, and we're not sure if AFOP is a precursor to RAS. Other things that you would think of that you need to exclude are strictures, PTLD, The B component in acute cellular rejection or lymphocytic bronchiolitis, recurrence of their primary disease, and of course, infection. We're going to skip that. If we take a look at bronchiolitis obliterans in specifically, there's a grading pattern, and what we didn't do before is in the past, when I first started doing transplant, we did not utilize azithromycin for BOS prophylaxis, but literature has come out that azithromycin in the use of patients who are post-lung transplant can help to prevent the progression to BOS, or maybe prevent as quick a decline. So now we are just prophylactically putting all of our patients on azithromycin if they tolerate it. So risk factors for BOS include, like we talked about, acute rejection, lymphocytic bronchitis, CMV, pre-transplantation anti-HLA, also things like recurrent community-acquired respiratory viruses. Risk factors, other risk factors are CMV, donors, DSA reactivity. GERD is a big thing that we take a look at because we are aware that this contributes to chronic rejection. Also older donor age and longer graft ischemic time, we believe that also contributes or can contribute to BOS. So this just kind of highlights, if you take a look at over time, as how much or when do patients develop BOS, I generally tell patients that at around 5 years, close to 50% of patients have some degree of BOS. That doesn't mean that it's incapacitating, but it may even be just BOS OP. It could be stage 1. And some patients can stay at that stage for a very long time. This highlights the fact that over time, OB and BOS in the red increases over the years and is basically the biggest limitation to long-term survival for our patients. So treatment. We don't have really good treatment. It doesn't respond very well to augmented immune suppression. I already mentioned that we've used azithromycin. We also generally have all of our patients on statins, which is also used as it has an antifibrotic effect. We perform fundoplication for GERD. We try to modify risk factors by treating rejection and infection and monitoring patient compliance. Patients whose tacrolimus levels are all over the place, up and down, and we suspect that they're not completely compliant, those variable tacrolimus rates have been associated with the development of BOS as well. So restrictive allograft syndrome, so another component of CLAD, is highlighted by upper lobe predominant pleural parenchymal changes. The survival is significantly worse than the survival of BOS. It tends to be more rapidly progressive. This is an example of a patient who has RAS and has, you can see looking at the arrows, the peripheral parenchymal types of changes. This is another very kind of wordy slide, but it kind of compares and contrasts BOS versus RAS. One of the things, for RAS, we also do not have very good treatments for, and I think we have fewer treatments for RAS than we actually do BOS. For BOS now, and there are a lot of studies taking into account extracorporeal photopheresis, which we are not currently doing at this stage in our hospital, but we are looking into it. We will sometimes switch immune suppressive therapies. There are some institutions who have tried methotrexate. Singular is also felt to be an agent that can be used, and I think it's reasonable. It has very, very few downside. I'm not certain of the exact mechanism of how that works. If you look at the median survival after diagnosis of BOSS at 2.5 years, I think it's important to note that RAS is quite a bit less at 1.5 years. One of the things that I think is, in fact, is interesting is that patients with RAS, they're exploring the use of some of the antifibrotic agents that we use for pulmonary fibrosis, so pirfenidone, and there are those looking at this monoclonal antibody as well. But I do not believe at this time that we really have any definitive treatments for that. So in conclusion, lung allograft dysfunction can be acute or chronic, and it can also accompany other conditions such as infection. The evaluation includes clinical, radiographic, pathologic, and laboratory elements. Acute rejection can be either cellular or humoral, or in other words, antibody mediated, and CLAD is the largest limiting factor for long-term survival post-transplant. And I think now I will ask if anybody has any questions, or actually, we're going to wait till later, right?
I think so.
Okay.
Seems like
Yeah. All right. So I will turn things over to Dr. Pinto, and thank you for your attention.
Okay, so the focus of the next 30 minutes or so is going to be on patients who have high LAS score. And I'm going to start with that because then we're going to transition what we are doing nowadays more frequently, that is ECMO as a bridge to transplant and ECMO as a bridge to decision to transplant. But just to begin, the LAS score was adopted in 2005. And the whole idea was to give the priority to the patients that were at higher risk for dying from their underlying disease. And it kind of accounts the survival within a year on the wait list and the 1 year survival after the lung transplant. So the score goes to 0 to 100. And basically, the higher the score, the higher the clinical acuity and the higher the severity of the disease. So sometimes when we run, we are going to say, the LAS score is 30, is 40, is 50, is 80, is 88, is 89. So the higher the score, the sicker the patient. And also the higher the morbidity and mortality, either during the waiting period and also in the post-transplant period. This is all this is how we calculate the LAS score and all the things that we take into account for that score. Goes age, height, weight, diagnosis, ILD, IPF are the ones who have the highest score. COPD patients are the ones who have the lowest score. And that's basically because we know that patients with IPF are probably going to die faster than a patient with a bad COPD. We take in consideration the functional status, whether or not they have diabetes, whether or not they have mechanical ventilation, amount of oxygen, PFTs, hemodynamics, six-minute walk test, creatinine. So you can see here that ECMO is not mentioned at any point. And that's important to know when people ask if the patient needs to be on ECMO or not. Because the short answer is that a patient who is on mechanical ventilation, high flow nasal cannula, or ECMO, they're pretty much going to have the same score. Why it's important to use the lung allocation score? Because there is a discrepancy between the supply of organs and the demand for organs. And we're trying to efficiently allocate those organs to the patients that have the probably highest mortality. This is very important, the transplant window. This transplant window has been moving more to the right lately, but it basically is a period of time since we initially meet the patient, or maybe the patient is seen by their pulmonologists or primary care physicians, patients who don't have any symptoms, or they just have an incidental X-ray that looks abnormal, and kind of they move over time toward having symptoms, having a diagnosis, having a treatment. They go on oxygen, and at some point they are on a ventilator, or they have a poor nutritional status due to the advanced disease, and at some point they die. So this transplant window again has been moving a little bit to the right lately. Now that we have more advanced medical therapies, and also this transplant window can use for any type of lung condition. Can be for COPDers, can be for patients with pulmonary hypertension, can be for patients with ILD. You have to choose, and for every disease, I think the transplant window is going to be a little bit different. You don't want to offer a transplant a patient who only has a minimal shortness of breath and don't require any oxygen, because you will likely be shortening the patient's life. You don't want to probably offer a transplant to a patient who is actively dying. But then, it's in this kind of dark gray area, that we're starting to see ECMO as a useful tool to improve outcomes with transplant. This study done, published in 2015, that takes a look at patients who have high LAS scores, and is from the SRTR registry, 10,000 patients. They have 4 groups depending on the LAS score. And there is, the group number 4 is the LAS score over 48 up to 95, very high scores. And they noted that, not surprising, patients with a high LAS score were patients who have fibrosis, or patients who were on mechanical ventilator and ECMO. Patients who have lower scores are the ones who have COPD. And we all know that. We know that we can have a patient with a COPD with an FEV1 of 0.5 liters, with a CO2 of 50, who requires 3 liters of oxygen, who can have a LAS score of 30, and then can be on a waiting list for a year, 2 years. And then we know that we can have a patient with pulmonary fibrosis who requires 4 liters of oxygen, with very decent PFTs that can have an LAS score on the 40s. So diagnosis is very important. But they saw that the use of mechanical ventilator and ECMO was associated to increase 5-year mortality. So the conclusion to this study was that the patients with higher score have a worse prognosis than patients who have lower scores, and that was not a surprise for anyone. And there's also a lot of studies that confirm this observation. So the question is, why, if you know that the outcomes are poor, why would you have to offer transplant to these patients, right? One is, and I think it's a very important reason, is that especially for patients with interstitial lung disease, we tend to meet these patients early on the disease course. So at that time, when they are initially listed, or when we initially see them, these patients maybe are not sick enough for transplant, and we tell them to come back in a year, and then things change, and they start requiring oxygen, and then we list the patient, but they still have a low score, in the mid-30s, low 40s. But we know that these patients are going to progress, and we know that 45% of these patients are going to pass that threshold of an LAS of 50. So at that point, what do? Do you just say, I'm sorry, I'm not going to transplant you because you're going to affect my numbers? Or do you just keep going? And we see these patients quite often, so we have built a good relationship with them most of the time. So we don't say no to those patients. We know that those patients have high chances of being on a ventilator or ECMO at some point. And we try to give them the chance with a transplant, because we know that, even though we know that there is a high risk for complications of transplant, we know that the disease that they are carrying has probably 100% mortality. This is a part of the prior study, and you can see here in the column here that a patient with high LAS score, 14% of those patients are going to require mechanical ventilation at some point, and 4% of those patients are going to require ECMO at some point, you know, compared to here 0.3%, 20%. So we know that those patients make it there, they don't get transplanted. We hope that they're going to be transplanted before that, but you know, the reality sometimes is just so ECMO as a bridge to transplant. Again, you have indications. We have absolute contraindications. We have relative contraindications. And the main indication is any patient with refractory hypoxemia, hypercarbia, right heart failure despite optimal medical management, who is a potential candidate for lung transplant. And obviously, the same way that we see look for contraindication for ECMO is, you know, in this case, would be a patient who is not a candidate for lung transplant, cannot be a candidate for ECMO as a bridge to transplant, patient who have any other organ damage, unless, you know, the institution is willing to provide a dual organ transplant. These patients are infected, not just a pneumonia, we're talking more like a septic shock type of thing, bacteremia. If there is any contraindication to anticoagulation, if there is metastatic disease, or any other terminal illness that will not fit transplant. You know, also, you know, severe neurological conditions are also contraindication for transplant. And then there are some other relatives that are, you know, the age, the obesity, frailty, sensitization, and time on the ventilator. So all these are the things that we kind of assess before we can put, or we decide to put a patient on ECMO. So the three questions that we have to ask is the patient a good candidate for ECMO? Should this patient be transplanted off of ECMO? And the big one, when we get consulted from the ICU, is when do we start this patient? And these are questions that don't have clear answers, and we usually go patient by patient on this. What do you consider? You consider if the patient has an acute event. Is there something acute that is causing the decompensation, and can that be recovered? Did you use all the other technologies available to make this patient better? You know, was the patient on mechanical ventilation? Was the patient on high flow oxygen? Did you try in other centers, nitric oxide, Flowland type of things? Can the patient rehabilitate in the future? Can the patient receive anticoagulation? Is the patient malnourished or morbidly obese? Again, organ failure, multi-drug resistant infections. Is a patient highly sensitized? I think that that's a big one. Patients who have a lot of antibodies going into transplant are probably not a candidate for ECMO. And if there's any contraindication for lung transplant on patients who are not listed. You know, since 2009, we started to see that institutions were using more ECMO. And we also saw that there are more articles and research done on ECMO since 2009, 2010. So ECMO is something that a lot of hospitals are using nowadays, and you know, we are using in this hospital on a more frequent basis now. When we talk about ECMO as a bridge to transplant, there are a lot of areas of controversy, and one would be age. The other would be bronchiectasis or CF, because that's related to multi-drug resistant infections, patients who are profoundly myopathic, patients who have multiple comorbidities, and patients who are sensitized. So these are areas of controversy that we see all the time on these patients. The experience on ECMO is mainly single center experience, single center reports. And you see there are multiple centers that have, you know, different amount of patients on ECMO through the years that can be as low as 7, as high as 60. and kind of they report their own mortality based on their experience. And you have a mortality that can be as, sorry, a survival that can be as low as 33% or as high as 93%. It's just to put this on perspective. The 1 year survival after a lung transplant in general for a patient who is not on ECMO is around 88, 90%. Okay, so that's kind of what we're looking at. So if you're at 85%, you're probably fine. If your mortality is around 33%, there's something that you need to improve. Sorry, your survival is at 33%. There's no randomized controlled trial for this. It's all a single center experience. And why do we see this discrepancy in the outcomes? Is because there are different cannulation strategies, different center experience, manpower. You can have a lot of complications post-transplant and pre-transplant. The donor, you're looking more like get lungs as soon as you can. So you're looking at high-risk donor, probably donors that were a little bit elderly, in the 50 years old, who maybe had some history of smoking. Also, the recipient, can have comorbidities. If we're talking about fibrotic patients under 50s, 60s, can have coronary artery disease, can have osteoporosis due to the use of steroids. And then also the time of ECMO, patients who have high amount of antibodies going into transplant. It's going to be very difficult to find good lungs for them, or lungs that are going to be a perfect match. Also extreme height, you have patients that are very short or very tall. Sometimes when the patients are very short, you're looking more for a pediatric donor as opposed to an adult. So all those things are going to affect the survival. And, as you can see, it's very variable. But through the years, if you see this graph, this one is early 2000s, this is 2009, 2011, we can see that the survival, that will be the bottom line, is getting better. So there's been an increase in 1 year survival from 35% in early 2000s to 75%, 2009, 2011. This was on a study published in 2015, and that's because centers are using ECMO more frequently, and they feel more comfortable using the technology, and also the technology has improved significantly. Also, there's a trend of doing only double lung transplant on these patients, opposed to single lung transplant. Again, a lot of these patients are going to cross that LAS of 50, and where these are patients who are facing a disease that has 100% mortality at that point. Just looking at how many centers in the United States use ECMO, there was a survey that was done and published in 2015. There are 57 transplant centers in the US. This survey was sent to the 57 centers. Only 33 of those centers answered the survey. But what we can see here that is that 67% of those centers are using ECMO as a bridge to transplant. Every time we talk about ECMO, we talk about the importance of having those patients ambulatory. Out of this survey, only 4 centers of the 33 centers that answered the sort of the 22 centers that were actively using had the patients ambulatory. It's possible, and it's very difficult. It needs a lot of education from the nursing staff, respiratory therapists, physician, physical therapy, occupational therapy, but it's definitely doable. The big question when we get these consults is, can you see this patient? If the patient is a candidate for transplant, we see the patient, seems to kind of progress, and then the question is if the patient is candidate for ECMO, and then the question is, when do you start ECMO? 77% of those centers reported that they rather intubate the patient first, and they place the patient on ECMO. Only 32% of the centers say that they can try to awake non-intubated cannulation. Out of those 7 centers, 6 centers were high volume centers. For this study, a high volume center was defined as a center that can do more than 50 transplants a year. Here, I think we tend to intubate the patient first, but there have been some occasions where the patients were placed on ECMO while they're awake. The other big question is why you don't use ECMO is because there is no interest either from the surgeons or from the institution. Is age a barrier for transplant? 45% of the centers said that 65, older than 65 is a contraindication for ECMO. But 36% of the centers said that age is not a contraindication. And that's kind of the way that we approach here. I don't think age plays it plays a role on the decision, but it's not an absolute contraindication. And the other big question that we ask, is for how long do you keep on ECMO? Because kind of that's a discussion that you have with the family. How long do we keep this going? When we look at ECMO as a bridge to transplant, 55% of the centers decline to give a maximum acceptable duration of ECMO. 30% of the centers at 10 days. I think here we don't have a maximum amount of time. We just go day by day. We're very clear with the family that patient and also the patients that they are aware that as soon as there's a contraindication for ECMO will be discontinued. But we have had patients on ECMO for several weeks, and they were successfully transplanted. And you can see this here. This is the duration of ECMO, and you can see some centers go from 4 days to 32 days to 48 days to 63 days, and there is even one case report of a patient who was transplanted after being more than a year on ECMO. So it's doable. It depends on how much are you willing to tolerate on those patients. And we always try to have this discussion with the patient, and we cannot have this discussion with the patient because the patient is already intubated. We try to have this discussion with the family. We have discussion with the family that ECMO will be discontinued if there is evidence of an organ failure, and we cannot offer a dual organ transplant. If there is a irreversible neurological catastrophe, or the patient is coagulopathic, it's bleeding, we cannot stop that. The patient's going to septic shock, or maybe the patient, said it's enough. The patient is awake, said, it's enough. It's been connected to this machine for 2 months, for 2 weeks. 2 weeks, I don't want to do this anymore, and that's another reason to discontinue it. Now, something that is new, and there is not too much information, and definitely not research at all, is what about ECMO as a bridge to decision to transplant? And that it's a point of controversy. I found this article from July 1st of last year in the Chest Journal, and I think it's a very short article, but really nice, well written, that I think everyone should read, where they give a point and a counterpoint about this question. Should patients with advanced lung disease be offered ECMO as a bridge to transplant if they have not yet been listed for lung transplant? And there is a yes and there is a no. I don't know what's the correct answer. I can tell you that here lately we've been doing ECMO as a bridge to decision. And what are the critical factors for this decision? And the main one is that, one, the patients have to have access to a specialized lung transplant and ECMO center that is amenable to do a rapid transplant evaluation. You are having a team that is going to imminently list the patient with whatever data they have available. At the same time, it has to be a consensus among all the teams, the ICU team, the transplant team, the surgical team, and it has to be consent. Consent in regards of what happens or when do you stop ECMO. That has to be very clear. Or what happens if, this few days that we're going to do an expedited evaluation, you found cancer, or what happened if the patient develops a stroke. That has to be very clear. So if you have this, there is a group of patients that definitely will advocate to do bridge to decision to transplant. Because we can have multiple scenarios. We can have the patient that, you know, we already know that is doing the evaluation, is about to complete the evaluation and then, you know, have the compensation. We can have the patient who is kind of starting the evaluation and then decompensates, and then you need ECMO to facilitate that that workup. Or we can see what we often see in the ICU, a patient that is healthy, that was never aware that had a lung condition, that all of a sudden is in the ICU hypoxia. You know, and lately we've been seeing that with COVID. The ideal bridge to decision patient would be a patient who already saw a lung transplant physician prior to the decompensation, who has a clear diagnosis of chronic lung disease, who is hospitalized in a center that can do transplant and ECMO, and can complete a workup in a short period of time, and the patient who definitely, you know, doesn't have a contraindication for lung transplant. You know, for example, sometimes we get consult for patients, and when we go to see them, they're bedbound, or they have been on, you know, smoking or doing drugs, or have you know, very decompensated psychiatric disease. Those patients wouldn't be a candidate for bridge as a for lung bridge to decision to lung transplant. And in order to be successful with this, from bridge to decision to bridge to transplant, you know, it has to be a consensus among the physicians, critical care team, the ECMO team, surgeons. It has to be daily interdisciplinary rounds, advanced care planning, palliative care, and very clear, outline very clear when ECMO is going to be discontinued. This is an algorithm that this article proposed. And it's kind of the same that I already mentioned, but basically you have a center that can offer lung transplant and ECMO, that can do an expedited evaluation here. And then if with the information that you have, are you willing to offer transplant? Because you have to be realistic, you know, you're not gonna have all the tests that we would like to have at that time. Is there a consensus among all the teams that are taking care of the patient? And if the consent was provided. If all this is yes, you can argue that the patient is a good candidate for ECMO as a bridge to decision, hoping that it's going to go to bridge to transplant. And if that doesn't work, you know, it's a palliative hospice type of care. What was the argument of no ECMO as a bridge to decision is that the outcomes are poor. And that was the only argument that they gave to, not the argument, the outcomes are poor and are worse than transplanting patients that are not on ECMO. And even though it was only a one paragraph, I think it's a very valid point because, you know, if you made the wrong decision, someone else could have gotten those lungs, right? So the question is, how much are you willing to take, and how much your center can offer to that patient? This was given to me of the database by I believe it's Crystal, one of the P5 nurses in charge of ECMO. Since 2017, we did 11 patients as a bridge to decision. Out of those 11 patients, 7 patients were listed, 5 patients were transplanted. All those 5 patients are still alive. You know, a few from 2019, one from last year, one from a few weeks ago. And you can see that the patients who were not listed, were one of those patients developed septic shock. 2 of those patients were on deep sedation and were not able to participate on their care. And we have another septic shock here. And as you can see, you know, at the beginning in 2017, it was no. And then as we go more in 2019, we have listed yes. So the big question is, how much are we willing to tolerate on those patients, you know? And the experience with the last two patients who were transplanted as a breach of the decision, I think is telling us that maybe, and I don't remember the details on these 2019 patients, maybe we could have tolerated a little bit more. But I guess maybe we didn't have the experience or the expertise to manage those patients. So as technology improves, I think we're doing better and we're tolerating more and we're having good outcomes for these patients. The very important things to see here is, you know, the workup time is not we're looking at workup time of 2 or 3 weeks or 4 weeks, you know. We are not picky about, you know, we need the pH or the manometry or things like that. Is, you know, what you have, and with what you have, you make a decision, and you can have workup times that can be as short as 2 days, you know, 7 days. This one, 12 days was because the listing was delayed because the patient wasn't stable at some point. But it's doable. It's doable with good outcomes, good quality of life, definitely. And in general, ECMO, since 2017, we transplanted, we had 23 patients on ECMO. We transplanted 13 of those patients. That can be either breach to transplant or breach to the decision that moved to transplant. And 11 of those 13 patients are still alive, you know. And again here, you know, the ones that were not transplanted was, you know, septic shock or acute renal failure, angioedema, or active bleeding or deep sedation. Here we have two patients who decided to withdraw care. There was a patient that was documented as too sick. So, and then again, at the beginning, we had a lot of no transplanted, and then we're more towards GS transplanted. So again, I think over the time we have learned to tolerate more things. We are more confident with the care that we can offer pre-transplant and post-transplant. And I think ECMO is a really nice tool to try to get to these patients to a successful outcome. Just to finish, you know, this is a patient, 70 years old, who was on ECMO 23 days. This one probably was 4 or 5 years ago. You know, this is her last X-ray. This is a patient who had HP, a 61-year-old who was on BB ECMO for 42 days. And this is her X-ray as an outpatient. And then the last two patients that we transplanted last month were also done as a bridge to transplant, and one of those was on BB ECMO for almost 4 weeks, and then transitioned to BA ECMO. You know, was on fentanyl, propofol, Precedex, Percet, oral narcotics, Nimbex. She was on Milrinone, inhaled Flolan, inhaled nitric oxide, and we were able to support her, and she was successfully transplanted, and she was able to go to rehab, decannulated with oral diet, walking. So if you choose the right patient, it's definitely doable. If you have the support from the institution and the resources, it's definitely doable. So that's all I have. And I know Dr. Franco was going to do this remotely, but I don't know how. There you have it. Right.
Dr. Franco, do you want to see if you're able to start sharing your screen? Dr. Franco, if you want to start talking, we'll see if we can hear you. Dr. Franco, are you able to start talking and see if we can hear you?
Hello, can you hear me?
Yes, we can hear you.
Okay, so can I start?
Yep.
Okay, I apologize for the technical inconvenience. Can you move to the next slide, please? Okay, the objectives of my talk are outlined below. Next. So treatment of COVID-19 is similar between immunocompetent patients and patients on immunosuppression after solid organ transplant. In the ICU, we know severe and critical COVID-19 patients are treated with a standard high-quality ICU care, avoiding further damage by the ventilator machine, and also self-induced lung injury in those patients who are not intubated. Next slide. In the latest iteration of the Society of Critical Care Medicine, the use of corticosteroids has been supported by several landmark studies, as well as remdesivir to shorten duration of hospitalization for those patients who do not require invasive mechanical ventilation. Other medical therapies are not included in these guidelines due to some conflicting results or lack of definite benefit. One of those drugs could be IV tocilizumab in patients that are already on corticosteroids. Next. In this study out of Henry Ford Hospital, early during the pandemic, 47 solid organ transplant recipients, mostly kidney transplant recipients, when compared to 100 non-solid organ transplant patients that were admitted during the same period of time. And this study was published in the American Journal of Transplant. As we can see here in the graph, most of the solid organ transplant patients in this cohort require hospitalization. The comorbidities were more common in the patients with solid organ transplant compared to those who did not have organ transplant. Diarrhea and renal replacement therapy were more common in the solid organ transplant group. But the mortality and need of ICU with ventilator was similar in approximately 22%. Interestingly, in this cohort of 47 solid organ transplant patients had lung transplant. None of them required increased mechanical ventilation, and she died. Next. Next slide, please. In this other study that included solid organ transplant patients from 68 intensive care units across geographically different regions in the U.S., over 4,000 patients were treated in the ICU between March and May of 2020. But the interesting of this case series is that they did a propensity score matching of 98 solid organ transplant patients. That included 4 patients that underwent lung transplant and 288 non-solid organ transplant recipients, and that were matched by comorbidities. And they reported on the 28-day mortality, which was similar and approximately 40% in both groups. In this study, again, diarrhea was a common symptom of presentation, and the only statistical difference between the two groups was the use of corticosteroids in the solid organ transplant group in 68% of cases versus 38% of patients which were not solid organ transplant recipients. The need of mechanical support, mainly invasive mechanical ventilation, was similar between the groups. Next. And we can see the rate of complications was also similar between the patients with organ transplant and those who did not have organ transplant, including development of thromboembolic event, as well as need of mechanical support with mechanical ventilator and ECMO. And in this graph also, we can see that patients that underwent organ transplant in the past, they require more renal replacement therapy. Next. This is a registry of solid organ transplant by the University of Washington that included over 150 lung transplant recipient patients. And we can see that the morbidity and mortality in this registry was reported in 1,900 cases of solid organ transplant with at least 28 days follow-up. And it remained, morbidity and mortality remained the same regardless of the season. Interestingly, over a third of hospitalized patients require ICU. Many of them needed invasive mechanical ventilation. and the 28 days mortality rate was approximately 15%. Next. So earlier during the pandemic, Temple University reported their experience on 9 patients that received lung transplant in the past. And they reported on the 28-day mortality, which was about 25%. 2 of those patients were fresh transplanted patients within 2 weeks before they got infected with the virus intrahospitally. They were extubated after lung transplant, but then when they got infected with the virus, they developed ARDS and they died. They described bilateral lung infiltrates in both lungs in patients that underwent bilateral lung transplant. And in patients that underwent single lung transplant, the ground glass opacity affected both lungs, the native and allograft lung. Next. This is the largest single center cohort of lung transplant recipient patients that comes from New York. They reported on 32 patients that had a median age of 65 and a median time from transplantation of 5.6 years. About half of those patients received bilateral lung transplant for pulmonary fibrosis. Severe COVID-19, they define as need for ICU admission or require a non-rebreather mask, Optiflow, or invasive mechanical ventilation. Most of these patients received therapy with usually administered drugs during that time of the pandemic. That was March and May of 2020. Many of those drugs are no longer recommended. Augmented corticosteroid therapy and tocilizumab were used in 44 patients with corticosteroids and 19% in patients with tocilizumab in addition to corticosteroids. The mortality in this patient was lower, was about 47% compared to those patients that did not receive corticosteroids or tocilizumab. By the study end, the mortality of those that require invasive mechanical ventilation was 100%. As it is common, management during infection in solid organ transplant, cycloside inhibitors was held in 88% of the cases. Next. In this letter to the editor, Hellman et al. Reported on ICU admissions amongst 11 hospitalized lung transplant recipient patients. ICU rate was 45%, which was not surprisingly higher than other solid organ transplant, as COVID-19 affects primarily the lungs. Of those that require invasive mechanical ventilation, mortality was reported in 71% of lung transplant recipients. Next. And this is our own cohort of 16 patients underwent lung transplant here at Henry Ford Hospital. Most of them developed mild illness and were monitored at home or required admission to the medical ward. One of those patients died. She was a 49-year-old woman who underwent bilateral lung transplant for sarcoidosis, and she survived her transplant 8 years. And she died of complication after ICU admission for ARDS that required invasive mechanical ventilation. Next. So when we look at mortality for severe and critical COVID-19 patients, we can conclude that patients that undergo solid organ transplant and become ill with COVID-19 have a much higher mortality rate, especially those that underwent lung transplant and require mechanical ventilation. Here in this table, I listed the different landmark trials that explore the mortality with different interventions. We can see that the mortality in general population is about 20 or 40% in those that requires ICU admission, whereas the mortality rate in patients that with lung transplant that require invasive mechanical ventilation is reported between 75% and 100% of those patients. We can see that mortality is much higher even in those patients that require the ECMO, as was seen in 2 studies by Schmidt and Barbaro, where the mortality rate in patients that require VV ECMO was 31% and 38% respectively. Next. So in regards to indications for ECMO in patients with COVID-19, the the Sacral Lung Support Organization have issued their recommendations on where to consider ECMO. As we said before in the previous slide, the mortality rate of 31% in centers that have high volume ECMO experience is not that much different of patients that were put on ECMO due to COVID-19 during the influenza pandemic and due to bacterial causes of ARDS. Next. This was already mentioned by Dr. Pinto, so I'm not going to spend time on this. Next. So in patients that have severe and critical COVID-19 infection, the also initial document guidelines recommend the use of ECMO in patients depending on the level of the strain of the hospital healthcare and also depending on the patient individual characteristics. We know that ECMO is resource intense, and during times of the pandemic where the resources are very strained, ECMO might not be a treatment option for our patients. Next. So the National Institute of Health don't have enough data to recommend in favor or against ECMO in patients with COVID-19 and refractory hypoxemia. Next. I think we can talk about this later, but basically the ICHLT recommends repeating tests for SARS-CoV-2 in patients that are considered donors, and this needs to be done at least twice and 72 hours prior to donation. Next. This is the same guidelines regarding suspected or confirmed exposure, how often the RT-PCR needs to be repeated. Next. We can move to the next slide. And these are all our guidelines that are in concordance with the American Society of Thoracic guidelines as well as the ICHLT. Next. So when is a lung transplant a life-saving treatment option? The answer is whenever a patient has end-stage COVID-19, also referred as a non-resolving COVID-19, the possibility of lung transplantation as a life-saving therapy should be considered. Next. So this seems to be the case for about 1% of patients that develop severe illness due to COVID-19. As in this study of 171 patients described the different histopathological features found in patients with severe COVID-19, and about 1% of those patients develop end-stage fibrosis. The most common histopathological features that we see here in the table are diffuse alveolar damage, organizing fibrosis, microthrombi, and pulmonary thrombosis. Next. This is the first largest case series of patients that underwent bilateral lung transplant for severe COVID-19 that is coming from Wuhan, China. 3 patients underwent bilateral lung transplant for irreversible lung disease. We can see the chest X-ray and the CT scan at the bottom of these 3 patients. Next. So they looked at the explanted lungs and they described the gross appearance, pulmonary parenchyma, and intrapulmonary vessels involvement. And as we can see in this table, these patients have a consolidation with large amount of mucus plugs, congestion, and hemorrhage. In the pulmonary parenchyma, they describe typical findings of severe ARDS, but we also see significant involvement of the intrapulmonary vessels. Next. This is a study that was published in Lancet, in the Lancet journal, that described the case of a 33-year-old woman in Vienna who underwent bilateral lung transplant. We can see in the microscopy the severely damaged lung, and in the CT scan the progression of the illness over time. In the histopathology at the very bottom, we see changes of diffuse alveolar damage, and in letter H, we see a microthrombus in the pulmonary artery. Next. This comes from Northwestern. They have the largest case series of patients here in the U.S. They describe on 3 patients that underwent bilateral lung transplant due to severe COVID-19 pneumonia. And again, we can see in the pictures in the middle, the microscopy shows similar findings of very congested lung, hemorrhage, and consolidation. Next. They even went a little bit further and looked at the microscopic distribution of the matrix. And in letter J, the picture in the left upper corner, we can see the pathology of a patient that died from pulmonary embolism without COVID, that they use as a reference of how the normal lung looks like, the lung parenchyma looks like. K, L, M, and N are patients that had either lung transplantation because of COVID-19 in cases of KLL, and M and letter N, those are patients that die from severe COVID-19 did not receive lung transplant. In all, we can see the matrix also very distorted in a patient with pulmonary fibrosis. So K, L, M, and N resemble the destruction of the matrix seen in patients with end-stage lung disease due to UIP in patients with idiopathic pulmonary fibrosis, which can be considered a prototype of very end-stage lung disease. Next. Common complications during transplantation were before, during, and after operation. Before lung transplant surgery, a lot of those patients develop hemothorax, pneumothoraces, bleeding complications, including intracranial hemorrhage, ventilator-associated pneumonia, and RV failure. During the operation time, there were technical challenges due to frequent adhesions, mesenchymal pleural and vascular adhesions, and bleeding associated to it, arrhythmias, and cardiac arrest. And post-op need of mechanical support with ECMO and renal replacement therapy were very common. Next. This is a report of the first patient out of Northwestern that received a lung transplant. It was a 20-year-old woman that underwent bilateral lung transplant. Next. And this is a picture from the Chinese colleagues, obviously using more appropriate personal equipment. Next. This is our own case of a recently transplanted patient after COVID-19. She's a 31-year-old woman with inflammatory bowel disease. She tested positive to SARS-CoV-2 on November the 20th. She delivered a baby on 11/27, had some complications, including severe preeclampsia. Was admitted to the medical floor on November 29. She was treated with anticoagulation, systemic corticosteroids, remdesivir, vitamin C, zinc, antibiotics for endometritis. She was moved to the ICU and almost within 24 hours due to persistent hypoxemia. She was intubated on December the 6th. Was placed on VV ECMO on December the 11th and tracheostomy on December 29th. VV ECMO was converted to VAP ECMO on January 10th. Next. She underwent bilateral lung transplant on January 16 of 2021. And here again, we can see in the picture of the explanted lung, a lot of hemorrhage and congestion as well as consolidation. Next. So these are the summary of the 9 cases reported in the medical literature. We can see that 5 cases come from China, 3 from Northwestern, and that 1 case from Vienna. In all cases, VV ECMO was used as a bridge to lung transplant. The median time from disease onset to lung transplant was 44 days, but it ranged between 37 to 100 days. All patients underwent bilateral lung transplant. One of the Chinese patients from the first series in the first column underwent heart and lung transplant, and he died due to intraoperative complications. Next. Those were only the reported cases in the medical literature, but just a quick search in the internet about patients that underwent lung transplant for COVID-19, we can see another 9 cases plus our own case, 10 cases of patients underwent lung transplant. Most of these patients were bridged with VV ECMO to transplant, except for 1 patient in the left upper corner. That was a patient in Texas who underwent bilateral lung transplant without need of invasive mechanical ventilation of ECMO. What is described in the press release article is that the patient was unable to be weaned off oxygen, high flow oxygen. Next. The University of Toronto issued some recommendations about when to consider a patient with COVID-19 for lung transplant. They proposed 10 predictors that need to be met in order to consider a patient for transplant. And those are listed there: age less than 65 years old, single organ dysfunction, sufficient time for recovery. So they don't recommend to transplant patients unless they were aggressively treated with best standard of care for at least 4 to 6 weeks. There has to be radiological evidence of irreversible lung disease, fibrosis, or severe bowel destruction. Patients should be awake and able to discuss transplantation, should be able to participate in pulmonary rehabilitation, or at least have the capacity and the potential of participating in pulmonary rehabilitation after transplant, etc. Next. So they recommend only bilateral lung transplant due to the frequency of bronchopneumonia and frequent cavitation that are seen in patients with end-stage lung disease, as well as the development of pulmonary hypertension in those that have severe irreversible ARDS. Shorter period of preoperative morbidity could be associated to a rehabilitation potential is also very important. Next. From the ISHLT, the recommendations are similar. Again, there has to be evidence of a single organ damage only. Patients that are treated with intensive care in high level of care for at least 28 days and that show no evidence of recovery. Single organ dysfunction, and patients should be free of the virus, 28 days free from the symptom onset, and at least 2 RT-PCR are negative for SARS-CoV-2 48 hours apart in order to be considered a transplant candidate. Next. So just to conclude this, we have to remember that a number of patients after acute COVID-19 might develop an autoimmune-mediated inflammatory lung disease. Next. Can you play those 2 videos? You can play the other one too, please. So in the left, we see a video of a patient with acute SARS-CoV-2 pneumonia. And a month later, this patient have evidence of consolidation, airspace disease that was treated with corticosteroids. And last time I heard about the patient, she's only requiring 1 liter of oxygen by nasal cannula. So this patient received therapy with remdesivir corticosteroids during her acute illness. And 1 month later, when she remained hypoxic and with significant respiratory complaints, she was receiving corticosteroids for a prolonged period of time and has some improvement. Next. Next slide, please. And if you can play both as well. There was a case here of 3 patients with organized pneumonia that was confirmed with histopathology with lung biopsy. And all 3 patients, it doesn't matter, the anesthesia, the images are very descriptive. So these 3 patients were treated with corticosteroids for over a month for what it was biopsy-proven organized pneumonia, and all 3 patients recovered. It was a case here that was published in Thorax. Next. Next slide, please. Okay, but I think that might be my last slide. I just wanted to conclude this talk by summarizing the important points of this talk. First of all, we need to recognize that solid organ transplant recipients have a higher rate of hospitalization. The reported mortality of patients with COVID-19 requiring mechanical ventilation is between 20 and 40%, but that is seen in patients that are immunocompetent. The mortality rate is much higher in those patients that underwent organ transplant. The case fatality rate might be higher for those patients that underwent lung transplant that require invasive mechanical ventilation with a mortality rate that ranges between 75 and 100%. Lung disease after severe and prolonged SARS-CoV-2 infection associated ARDS share pathological and molecular features with idiopathic pulmonary fibrosis. All reported cases for lung transplant for COVID-19 were done in patients unable to be weaned off ECMO. And some patients might develop post-COVID-19 lung disease, possible autoimmune mediated, and they could benefit from a longer treatment with corticosteroids. Thank you. I don't know if we still have time for questions.
Thank you very much, everybody.
You're welcome.